Hey guys, what's up? What's up? Gonna kind of let everybody in here. Thank you guys so much for joining me. Feel free to turn your cameras on if you've got them. I like to see people's faces sometimes. It's nice to connect with you guys. Where is everybody joining me from? Put in the chat, like where are you guys coming at me from? I'm here in Gainesville, which is like, oh, maybe 30 minutes or so outside of Washington, D.C. So Toronto, awesome. Hey Ariel, how you doing? Scotland, ooh, you're joining from a far away. Love it. Dumfries, oh, you're not too far from me. I got all over the place. Oh, hey Ed from New York. Oh, it's good to see all of you guys. Thank you so much for coming and spending the afternoon with me here, spending the next hour with me. I'm super excited to talk about this. So today, what we're going to be covering is helping you better understand impingement and labral tears and all these chronic hip issues that are probably you're struggling with, which is why you found me. So we're going to talk a little bit of like just kind of breaking it down in a way that is a little bit easier to understand. We're going to go through a couple easy, like three easy self assessments that you guys can do on your own. And you can do them right along with me if you'd like in this session. That way you can kind of ask me questions and tell me what's happening. And then we're going to go through a couple exercises to get you jump started on what you should do. So once we know we do these assessments, it kind of tells you a little bit about what's going on in your hip. And then you should have a good idea of where you need to start exercise wise. So if you guys have been following me for a little while, I don't know where exactly you're all, found me, whether it's on TikTok or Instagram
This
or
is the lady that I went to see out in Gainesville.
oh, sorry, Susan, were you saying something? Hang on. Nope. Okay. All right. I was gonna say just I heard somebody talking there, but I don't know if you meant to do that or not. Yeah, if you guys have any questions or whatever, just drop them into the chat while we're going here. And then at the end, I'll go back through, or kind of as I'm going through, I'll try to answer them for sure at the end, but we'll kind of see. So just drop any questions that you have into the chat. But yeah, so if you guys have been following me for a little while, you probably have heard me say numerous times how important it is to understand your movement patterns and have an idea of what's happening and how your body is moving before you start to load strength on top of it. And this is an extremely important piece of the puzzle when we're looking at how we solve this issue of impingement and labral tears from a conservative standpoint. We really have to have a good method and strategy that we're following. So, my framework that I use with all of my clients, I'm going to kind of share it with you guys before we dive into anything, because I think it'll help you make a little more sense of like why we do things the way we do things. So, the framework that I use is in phase one. It's a lot of learning what is happening in your body to have a better understanding of what's going on, and then calming down the symptoms. So you have to understand your body before you can understand what do I need to do to calm my symptoms. I have to know what are my triggers, what makes it feel better. Are there certain exercises that work better than others? Are there certain day-to-day movements that don't feel great compared to others? Once I have that better understanding, I can start to figure out what are the things that I can do that make my pain feel better and calm my hip joint down. Once the hip starts to calm down, that's when we can then start to work on movement patterns. Now, for a lot of you guys, I would say, this is the piece that is most often overlooked. It's usually what most PT places miss, and they just jump straight into the strengthening piece of it. It's what a lot of people who have tried everything that they can think of. This is often the thing that they haven't tried, which is learning how to move with good patterns. Now, this is the piece that we are going to focus the majority on today, because again, it's the piece that's most often overlooked. So if you're like, what the heck does that even mean? I don't understand. I will explain it to you. Don't worry. By the end of this, you will know exactly what I mean when I say move with good patterns. And then once you've learned that piece, now strengthening makes sense. Again, most of the time what happens is we jump into strengthening right away. And then people are like, I've tried everything. I did PT and nothing worked and it just made it worse. And the problem isn't usually that you're not strong enough or that you didn't do the right strength exercises. It's that you didn't do them properly. So you were loading a joint in a way that was almost reinforcing the dysfunction and the problem. And so again, if we can learn how do I move with good patterns that actually reduces some of the tension in the joint and the compression in the joint. Now when I strengthen, I'm going to be strengthening the patterns that I need to manage this conservatively. So it really helps build a stronger, more supported, more stable joint and a less irritable, painful joint. From there, the fourth phase that I walk people through is sort of like the higher level. It's how do I make this like part of my day-to-day life? You've done all these things that have gotten it stronger, that have made it feel better. Now, how do we make sure that we can implement it into your life in a way that makes sense for you? You know, getting back to like whatever your goals are. Maybe it's running a marathon again. Maybe it's dancing again. You know, whatever those goals are, it's how do we turn this program into something that is sustainable long term so the problem doesn't come back. So those are the four phases that I walk people through. No matter how people work with me, it's always those four phases. And then what we do in each phase differs depending on your individual situation. But we call it the core framework. So the C is calming, the O is optimizing movement, the R is rebuilding strength, and the E is elevating performance. So you will often hear me refer to that framework, and that is what it means. So that being said, I'd love to hear from you guys. What brought you here? Why did you, want to come to this webinar? Are you struggling with impingement? Do you have a tear? Have you had surgery? Are you debating surgery? Do you feel like you've tried all the things and nothing has worked? Let me know a little bit about like what's going on for you guys, because that often helps me know kind of what we need to talk about, and make it more real for you. So I'm going to dive into talking a little bit about the anatomy of things. And so for the anatomy, I think this is a really important piece of the puzzle before we start looking at assessing. You first sort of have to know and understand like what are we even looking at? And then the assessments will start to make a little more sense of why we're kind of testing things the way that we're testing things. So this is your hip joint here. There's two parts to it. It's a ball and socket joint. So the ball is the head of the femur, or this is the thigh bone, right? So this is the ball here. And then the socket is on the pelvis. So it fits right inside of there. This, you will often hear the term impingement referred to as femoroacetabular impingement, which is a big long word for hip joint, basically, but that's what it stands for, femoroacetabular impingement. So femur, acetabulum, ball, socket, however you want to look at it. So again, ball and socket joint, which means this fits really nicely in here. It's a pretty snug fit. It's a very secure fit, unless you have something like dysplasia, which dysplasia, I don't know if any of you guys are struggling with that, but dysplasia is when this socket is too shallow. And so instead of having this nice, secure fit of the head of the femur in there, this is a little bit flatter and more shallow. And so it doesn't fit as securely inside of there. So there's a little bit more joint instability. So that's sort of how the joint is shaped. Now, on top of the joint, we have ligament, and our ligament is not elastic like a muscle. So once it gets stretched, it doesn't go back. But the great part about that is it provides a lot of stability to this joint. Now, the reason I bring up ligament is because many of our people who are struggling with impingement and labral tears also have some hypermobility or EDS possibly. And basically what this means is the ligament around the joint isn't as strong or as stable as it is maybe for somebody else. And so there's a little bit more instability between these two bones here because the ligament is ultimately what connects bone to bone. So I just bring that up just because I know a lot of you guys potentially are also struggling with hypermobility. These are very common things that go hand in hand, and that's basically what that means. Dysplasia is a lack of stability from like a bony standpoint, so the socket's too shallow. Hypermobility is a lack of stability from the ligamentous and like muscular support. Okay. So hopefully that makes sense from a bony standpoint. Now, there's also on the inside of the acetabulum or the socket, this is called the labrum. So there's this ring of cartilage right here. It helps deepen the socket and creates almost a little bit of a suctioning effect that helps really hold the head of the femur into that. It deepens it a little bit more for it. And sometimes we can tear our labrum. So the labrum is great for providing cushion. It's kind of the support or the cushion effect between the two bones, which this is a weight bearing joint, so we do need some cushion there. But there's going to be normal wear and tear on it. So labral tears are fairly common. And it's important that you know you can walk around with a labral tear. In fact, a lot of people have a labral tear and they have no idea that they even have a tear unless they do something that was to irritate it. So, a big question I get is, well, what the heck? Like, don't I have to have surgery if I have a labral tear? And the reality is you don't, because we know that people live with them all the time and they never have an issue with it. The most important thing is that we learn how do we move the joint in a way that doesn't create stress on that labral tear and inflammation. And again, that's kind of what we're going to talk about today. But it is certainly possible. So what happens when you tear the labrum is essentially a little bit of this cushion here. Kind of, you get a little tear in it, a little break in it. And what will happen is it acts almost like a little hangnail on the inside. And so now, instead of this nice smooth movement of the ball and socket, that hangnail sort of gets caught in there and it creates this like tugging, which is the pain that you feel. It often will feel like a pinch. Sometimes it will feel like a popping. It feels like compression, a deep aching. So sometimes when you can't pinpoint it from the outside, it's coming from a little deeper inside of the joint. And that, I would say, the catching is probably the number one indicator that there potentially is a tear. So when you go to move, the hip feels like it actually gets stuck or it catches. That's often a sign that it's kind of like flapped over a little bit and gotten stuck in there. Now, I mentioned you don't always have to have surgery on a labral tear. Keep in mind that there are cases where surgery is the right option, because if that tear is big enough, no matter how you move or change your movement, if we can't get it to stop catching, it's going to create a lot of limitations for you. And so the people who do all these movement tests that we're going to do, and they do all of the exercises and they learn how to retrain their movement really well, but they're still having catching, those are often the people who do really well then having surgery. No matter what, though, the most important thing is if you are on the fence of having surgery or not having surgery, you have to learn this stuff irregardless. Because even if you have a surgery and it cleans out that little bit of a tear, you still are probably struggling with the very movement imbalances that led you to have the tear in the first place. So many people who end up having the surgery still end up having pain after if they never learn how to move in a way that doesn't create a problem. So if you are on the fence, don't worry, this is still for you because you have to learn this stuff either way. And if you've already had surgery, it's not too late. You still have to learn it. So this will help you no matter where you land on that. The other little piece of impingement that I want to chat about is the structural side of impingement. Okay, so and this is like the bony changes or structural changes that can happen. So we have the head of the femur and we have the acetabulum here, right? So the socket. Sometimes what happens is we can have a little bit of extra bony growth on the head of the femur or on the socket. So instead of this nice round ball, there's like a little bit of extra bone here or a little bit of extra bone on the acetabulum, which means that when I go to move my joint, I don't have quite as much space. And so sometimes we get some compression and some pinching or irritation earlier in the movement that we should, and we sort of lose a little bit of mobility or range of motion. So you can also potentially have surgery to shave down that bony overgrowth or bony irregularity to try to make things glide a little bit smoother. That being said, again, just like with labral tears, many people have these structural abnormalities and don't even know that they have them. So if you've ever been diagnosed with something like a pincer impingement or a cam impingement, that's basically what this is. Extra bony growth on either the head of the femur or the acetabulum, which creates some extra compression. So again, people usually say to me, well, if it's a structural problem, don't I have to have surgery? And my response is not necessarily, because many people have these structural issues and never have a problem at all. They'll do studies where they take an x-ray or an MRI of people's hips who have zero symptoms. And like 60 to 70% of these MRIs will come back as something diagnosable, right? Maybe there's a structural abnormality or a labral tear, but these people have zero symptoms. And they've done this many, many times. And that's pretty much always what they find. So we know that it is possible to live with some of these structural abnormalities. We can't change structure from the outside, right? As a physical therapist, I can't change what your structure is. But what we can do is we can teach you how to work with it and how to move in a way that doesn't create that excessive compression, which is going to create the irritation and inflammation, which then causes the pain. So here's the piece that is most commonly missed with impingement and labral tears. It's not always structural. Many times it is functional or movement based. It is absolutely possible to have a structural issue and a movement based issue going on simultaneously. In fact, most times that's exactly what's happening. Sometimes there isn't even a structural problem, it is just a movement based problem. So again, you go in, you have surgery, and there's nothing structurally going on there, kind of not needed, right? So it is really important to pay attention to the movement piece of this, which of course is what we are going to talk about now. And so what does that mean? So how is the head of the femur supposed to move here? So ideally, kind of at the center of all of this, and it's going to be the same when we get to the assessments and to the exercises. The most important thing that I want you to know is when we're going to go into the movement of hip flexion. So when we flex our joint here, the head of this femur must stay in the center of this socket. And I say flexion because that's the most common direction that often creates a pinching for people. However, it doesn't matter which way you're moving. Rotation, extension, out to the side, which is abduction, adduction. This head of the femur must stay in the center of that socket, which means there's a little bit of rolling and gliding that has to happen in there. This isn't something you can see or feel from the outside. It's something that's happening deep inside that joint. And what controls that good stability and movement is all the dynamic muscle support and stability around it. So it's kind of a combination of having enough mobility, having enough strength, having enough coordination, all of that. But it helps keep the head of the femur centered in the socket. So in the case of impingement, what often happens, as I mentioned, flexion, so pulling your knee closer to your chest, internal rotation, which would be like this way, so your foot coming out, and adduction or coming across. That combination of movements is what we call the impingement position, meaning naturally for everybody, it closes the space off between that joint. There's just a little bit less movement or less space there. In the case of someone who has impingement, that now either becomes painful or irritable, or it happens too early on in the movement. So sometimes I barely even flex to 90 degrees and I feel that classic pinch. The reason that we're generally going to feel that is because when you flex, if the head of the femur does not stay centered in the socket, which to stay centered, it actually has to glide down and back a little bit. Again, very small motion. But if it doesn't do that, it actually pushes too far forward in the socket. Now, it does not come out of the socket. I'm just going to do this to show you. It pushes too far forward. We get too much compression on the front, and then we flex the joint and we get that bony that it's hitting, right? But if it glides down and back into the socket, it clears the space, and now I have freedom of movement. So you can see it probably a little easier with my hands. When I go to flex the joint, head of the femur has to roll down and back into the socket to stay centered, so it clears that space. If it doesn't, it rides forward, we get the compression. And that is that classic pinch that you feel. Now, again, the most common times that we're going to see this happen is when we flex, when we adduct or bring across the center of the body, and when we internally rotate. because naturally it takes a little bit of the space out of it. It just naturally, there's less space there. So in a symptomatic hip, that is going to happen too early in the range of motion, or it's just going to be really painful compared to somebody who doesn't have a symptomatic impingement and they can do that movement with no problem. Does that make sense to everybody? Does anybody feel, type in the chat if you're somebody who feels like, what's your symptom? Is it a pinch? Is it a catch? Is it an aching? Is it just pain? Like what's the symptom that you feel? And also what's the movement it happens with? So some of the really common movements that we see it happen with is, so anything flexion based. So it could be squatting. It could be bending over to put on your shoes or tie your shoes. It can be going up and down a stair. So lots of different things like that. These are the common ones that we see. Another really common one is like bringing the leg in and out of the car. That's a big one. So what do I see here? I see some pinching. Oh, you get pinching and extension. And actually, I think, let's see, no pinch or catch, just constant soreness, tightness. Pinching and catching with flexion and internal rotation. Yeah, absolutely. Yeah, so Freddie, I saw your question in there that you can also have a posterior impingement. So, which is absolutely possible. So everything that I'm sort of talking about here is an anterior impingement, which is the pinching happens on the front side of the joint. And before I mention the posterior impingement, I'll just say too, so just so I can kind of tie it into labral tears. So what happens again with that forward glide is you get this repetitive compression here. Well, on the front part of the joint, this is where the labrum is the most exposed. So often that repetitive motion is what's wearing down the labrum and creates the tear. So again, this is where it is movement based, because if the head of that femur isn't staying centered and we're getting too much forward compression over and over again, I'm going to end up with a labral tear. Now, structure can also play into that, because if there's too much bony growth here, I'm still going to get compression. But again, can I teach you how to move in a way that still clears that space? Possibly, absolutely. So that's the anterior portion of impingement. There is also something called posterior impingement, which is really similar, honestly, but it's just that you get the pinching on the back side of the joint. So the pinching happens back here. It's a little less common just because of mechanics, but it absolutely happens. It's probably why you have a harder time finding resources on it. And in this case, usually the pinching is on, so there's like a nerve, it can either be a nerve, or there's also a muscle that runs through here. And so sometimes what happens is when we rotate or move in a certain direction, it actually compresses and pinches on the muscle. So it's usually not, the impingement usually isn't because of the labrum, it's because it's irritating muscle. Now, whether it's an anterior impingement or a posterior impingement, the movements are often quite similar that we're still going to do, because it is about building really good mechanics in the joint, and it's about stabilizing in a good way. But the directions that you do things might vary a little differently. Oh, my phone's ringing. I don't know if you guys can hear that. I forgot to turn it off. I apologize if you can hear it. The movements might vary just a little bit differently, because certain directions will impinge on the posterior capsule. So that would be like going into extension, a little bit of external rotation tends to cause more pinching here, where on the front it's opposite. It's flexion and internal rotation. So the directions that you do things might just be slightly different, but overall the idea is still the same. We have to learn how to move with good patterns, keep the head of the femur centered in the socket, and then stabilize and strengthen on top of that. So hopefully that makes sense. So that's sort of like what's happening. I think that piece often like can be really confusing of, I just don't even know what's happening when I have impingement or labral tears. So the exercises don't make sense. Like, why do I have to do this? Or like, how do I move in a certain way? And so when we understand mechanically what's happening, now as we move into the assessment piece, hopefully they make a little bit more sense, because you sort of know what's supposed to be happening in that joint now. So that's what we're going to move into. We're going to move into 3 assessments. And these are 3 things that I do with pretty much every single client, whether I'm working with them virtually, if I'm working with them in a group, if they're doing my self-paced course, if they are in the clinic, like they are doing these tests. because they really give us a lot of information and they help you kind of feel what's happening in your body. So I'm going to walk you through the 3 tests. Feel free to do them alongside with me. That way you can give me some feedback on how they feel for you, or you can just watch the replay and do this again later. But the first test that you're going to do is something called just a standing march. And so what you will do is you're going to come to a standing position. All you're going to do is you're going to take one leg, you're going to pull your knee up towards your chest. So, first off, what you're kind of paying attention to is, do I have full range of motion? How high can I get that leg? And when it's up there, what do I feel? Do I feel a pinch? Do I feel pain? Like, what's going on, right? So I'm just pulling knee to chest, taking note of what I feel. And then what you're going to do is you're going to try to keep your knee where it is, but let go with your hands. So I hold, let go. You are trying to not let that leg drop down. Now, if it does, and that's okay. That's part of the test. But the goal is to try to have it to not drop down. So what you want to look at is, if I pull my knee towards my chest, do I get the pain? Do I get the pinch? Which honestly is kind of common because we're going to end range flexion. So if you're feeling impingement, it's kind of normal to feel this, or common to feel it. But then you're also taking note of, when I let go, does my pain get worse, or does my leg drop down? So what does that tell us? If I pull my knee towards my chest and I get the pinch right off the bat, again, what's probably happening is we're getting some compression at the front of the joint, okay? Which again, fairly common if you're struggling with impingement. I would almost expect you to feel that. What I really want to know though is, when you let go with your hands, can you hold the leg in the air, or does it feel worse? What that tells me is, suddenly I move from what we call a passive range of motion. So knee towards the chest, passively, I'm holding it there. When I let go, it turns into active. Active now means the muscle has to control and hold my leg in the air. What this tells me is, if all of a sudden, so yeah, I'm already seeing it feels worse. My hip flexor feels like it's on fire. Yeah. So again, these is a very common finding. What it tells us is your mechanics are off. Okay. So it's not just a range of motion problem, because I can get my leg there, but when I let go, my pain actually intensifies. Meaning, when my hip flexor takes over and actually has to hold my leg in the air, there's a problem. It doesn't feel very good anymore. So that could be a couple things. It could be that I have some irritation on my hip flexor. Maybe I have a little hip flexor tendonitis going on simultaneously. Maybe I don't have tendonitis, but my hip flexor just isn't strong enough to hold and support good mechanics in full hip flexion. Many people, again, their pain happens when they go into flexion, but it's not always just because of structure. It can be because the muscles that are supposed to be holding you and pulling you there aren't doing their job. Maybe they're not strong enough. Maybe they can't support themselves. Again, a couple different reasons that we might see this happen, but it tells us there is a problem with the way the muscles are functioning and firing and coordinating. If the leg drops down, so sometimes it just intensifies in pain. Sometimes you physically can't hold it anymore. That tells me, okay, my hip flexor probably isn't strong enough to do the work. But either way, it means we have to eventually work on this active hip flexion. We need to get your hip able to withstand the ability to lift the leg up against gravity. The hip flexor needs to be able to work and coordinate so that it's not reproducing your symptoms. One of the things that will happen if hip flexor is not doing its job like it should be is some of the other muscles in the front of the joint will take over. So there's a muscle there called your TFL, your quads are there, your adductors, or like the groin muscles, are there. And so if hip flexor isn't strong enough, these other muscles try to take over. And what they do is, because of where they're attached, it actually creates more forward compression in the joint. Okay. If my hip flexor is strong enough and able to do its job, the head of the the head of the femur stays better centered in the socket. So what muscle you use to flex your hip matters. And if you get pain with this test, it tells us that something just is off there. We still need to sort of figure out what exactly is off, but we know the muscle timing and the coordination isn't what we need it to be. So hopefully that one makes sense. So it sounds like some of you guys for sure that was a positive test. Don't worry, I'll show you a few things to do for it afterwards, but let's go through all of the assessments first. So that's the standing march test. The second one that I want you to try is a quadruped rock back. Now, this one you're going to come to hands and knees for, okay? And what I'm going to have you do, I'm actually going to explain these next two tests together, and then I'll explain kind of what they mean afterwards. So the first part of this one will be the rock back, which is just hands and knees, and you're just going to try to rock your butt towards your heels. Now, as you do this, what's really important here is you do want to try to keep a neutral back versus rounding your back. Or most of the time people don't do this, but too much arching. So one of the things that I'm looking for as you do this movement is how far can you get before your back starts to kick in and move. The most common direction that we are going to see is when people start to tuck under. So usually a lot of people with impingement, their natural reaction to, instead of being able to flex their hip joint, they tend to take over and flex with the spine instead. So that's actually one of the things that we're looking at. Can you even do this with a neutral spine? You may not know, you might have to do it in front of a mirror, and that's okay. And then we're also just looking to see how far in that range of motion can I get, and what do I feel? Do I feel a pinch? Do I feel pain? What's happening there? Now, this is one that you can play with a little bit. So for some people, a little bit of a rounded spine actually takes the pinch away. For others, a little bit of an arch takes the pain away. So you kind of can do it in all three of those positions to figure out, where does my hip feel best? Another thing that you can try if you are feeling a pinch is you can open the knees a little bit wider and bring, let's see, what angle can you see me? Maybe this way. Knees a little wider and toes touching together. So I open that space up in the joint. And then again, I do that rock back. Can you get further? Most people who have an impingement feel a little bit more comfortable in a slightly turned out or rotated open position because it opens the space of the joint a little bit more. So that's one thing that you can try. And again, that kind of tells us what is your happy position of the joint. Because as we talked about in the framework, step one is calming the symptoms. So we have to learn, how do we move in a way that calms the symptoms? Sometimes it can be as simple as, when I flex my hip joint, I'm just going to open a little bit wider than I normally think I need to. I don't need to be straight in line. And so it's kind of important to know where you feel the least amount of symptoms, but can get the most amount of range of motion. So that's sort of what you're looking for in assessing there. Do you get the pinch? What's your range of motion like? And how does it feel? That's going to piggyback onto this next test, or this last test, which is just going to be a squat test. So all you're going to do is you're going to come to standing and you're going to do a squat and see how much range of motion can you get in that squat. Now, I will tell you what I see most common, which is somebody comes in, they're struggling with impingement, they go to do a squat, and this is what it looks like. And then they have pain. That's about as far as they can get. Or they're like, I feel like I'm going to fall over. And they just like, that's it. They're done. That's it. And then it reproduces that groin pain, that pinching. So squatting is often a really big problem for people who have impingement and labral tears. You might feel the catch, you might feel the pain, any of those symptoms. So the reason these two things go together is this. If you are somebody who cannot get into your full range of motion squat, this hurts, I can't get here. But when you're on hands and knees, you can get past 90 degrees or all the way back. Like, you have a decent amount of range of motion, especially if you open your knees up. Well, what does that tell me? This right here is the bottom of a squat. You're just flipped on your side. So what it tells me is you are capable of getting into that squat. You have the mobility available to you, but what you don't have is the coordination and the control in this case against gravity, to be able to actively get into the squat with good mechanics without feeling the pinch. So essentially, you're not able to move the head of the femur in that socket in a way that creates or reduces the compression. The head of the femur very likely is not staying centered, but the range of motion is there. So now that tells me we just need to teach you, how do I move in a way that can get you into that squat that doesn't reproduce pain? Did anybody test that one to see if they can do like one or the other? Now, some people still are not going to get the range of motion in the rock back. And again, there's some little tweaks that we often will do there. But for the most part, I do find that most people can get further in the rock back than they can in the squat. Let's see. I don't have much pain or pinching during the movement. It comes after I stop. Oh, that's a good point. Because I hear this a lot where people are like, it's fine during, it's the afterwards. So like, how do I know how much I should push? In this case, we're still looking to see in these tests, are you getting any sort of symptoms, right? Like even a little bit of a pinch, a little bit of discomfort, like a lot of times you'll still feel maybe a little bit of something, not always. So we're still looking for symptom reproduction. But the other thing is to know, so this is where learning your patterns is really important. Well, what are you doing that it comes on after? Have you just done a bunch of squats at the gym? Have you just done a bunch of like heavy lifting? Was it a lot of walking? Like what are the certain activities that you then feel afterwards? Because that still pinpoints to where the movement problem might be. And it's going to be different for everybody, but learning to track your symptoms will help you the most if you are somebody who doesn't feel it in the moment, you feel it after. Because a lot of times it's hard to put two and two together of like, well, what the heck did I do that even flared that up? But if you start tracking it, you'll start to see the pattern. And it still will tell us a lot of information, because then it's like, oh yeah, every time I walk more than a mile or whatever, that seems to be what's flaring it. Okay, so that we sort of have an idea of what movement we think is the problem. It can be really difficult to track, but I promise if you start like physically tracking it, you will probably start to notice a difference. And actually, pretty soon here, I'm going to do my challenge, the 21-day challenge again, which is there's an app that I made that you guys can actually track your symptoms for 21 days, and it pops out, it like populates information to tell you what your patterns, your hip flare patterns may be. So keep an eye out, because I'm going to be opening that challenge back up here soon. I don't know exactly when, but keep an eye on your emails and social media, because that will be coming back too. And if you are somebody who is like, it doesn't hurt during, it hurts after, you definitely need to track the symptoms. So this is an easy way for you to be able to do it and actually kind of get some information out of it. It does give you some responses based on the info that you put in. So, but yes, so those are the three tests: the standing march test, the quadruped rock backs, the squat test. What we're trying to find is which, if any, reproduce symptoms. And you're really trying to figure out, is it a mobility issue? Can I not get into that position to begin with? Or can I get into the position, but when I have to actively use the muscle, that's when my problem comes on, because that tells us it's more of a stability and a coordination problem. Once we know that, if we know if it's mobility or stability or coordination or what combination of those things it is, now picking the exercises to start with becomes a whole lot easier, because this is where we can target what your actual imbalance or impairment is. So we're going to go through we're going to do 3 exercises that are pretty safe for most people to start. Now, of course, everybody is going to be a little different. There's little tweaks, little changes, and things that, are going to be unique to you. But these are 3 things that I feel pretty confident giving most people that have symptomatic impingement or labral tears, because at the very least, it's going to address one of the movement problems that is likely going on, one of the patterns that we're likely seeing. So we're going to talk about 3 different things. The first being diaphragmatic breathing. Now, this one isn't necessarily attached to one of these tests that we did, but what I will say is almost every single person that I work with, no matter what capacity, diaphragmatic breathing is one of the very first things that I teach them. And the reason being is it has a lot to do with helping us find length in our pelvic floor, which are also our hip supporters and stabilizers. And for many people who have pain, especially chronic hip pain, we tend to guard and clench through these muscles almost as a way to protect. So, what we'll often see is there's a bit of instability in these hip stabilizers. And what will happen is the muscles naturally, they crave stability, right? So they tense and they guard up and they create essentially this false sense of support. They're like, "Ooh, look, I'm so strong, I'm so stable, all is well." But the reality is, it's not an effective use of the muscle, it's just clenching. So instead, what we want to do is we want to teach that muscle, how do I release and unclench so that eventually, when I start strengthening, I'm actually getting an effective use of the strength. And so the first piece of that is just figuring out, how do I not clench all the time? And we can do that with diaphragmatic breathing. It's a great way to downtrain that nervous system, re-regulate the nervous system, not only from a sense of that reflexive muscle, tension and trying to find stability, but also just when you're in pain, what's the reaction is, I'm going to guard, I'm going to tense. More guarding, more tension often creates more pain. It also creates more pressure on the front of that socket. And so we need to be able to release and relax through these muscles. So if you've ever done diaphragmatic breathing before, it's just regular old diaphragmatic breathing, nothing special about it. But what I will say is I definitely want you to pay attention to what's happening in those deep glutes and pelvic floor muscles. And so if you think about your abdomen as a canister, so the bottom of the canister being your pelvic floor, the top of the canister being the diaphragm and the rib cage. When you do the breath work, what you want to think about is inhaling and filling the canister with air. And then when you exhale, the air recoils back out. You could also equate this to a balloon, right? So if I inhale, blow into the balloon's going to inflate all the way around. And then when I let the air out, that would be my exhale, and the air just recoils back out of the balloon. So that's what we do with our diaphragmatic breathing. We're learning to manage pressure within our abdomen. Now, again, why is this important? For starters, it helps re-regulate your nervous system. So if you're somebody who's been living in fight or flight, a lot of pain, a lot of guarding, kind of that reflexive muscle tension, it's going to help reset the nervous system to let go of some of that. And then also, it is physically going to help you find some length in your pelvic floor muscles, which are also your hip stabilizers. So rather than going through the ins and outs of how to do the pelvic floor lengthening, what I'm going to do is in the recap email that I send you guys, I'm going to attach a video in there. It's about a 4-minute video that explains how to do diaphragmatic breathing. I want to make sure that I can get through the other exercises. So I'm going to send that video to you guys so you can watch it as many times as you need to. You can practice along with it, but just help you find, like, what does it even feel to find length in these pelvic floor muscles? So I'll send that video along separately. So diaphragmatic breathing, step 1. The next exercise, this is where we start to get more into the movement piece. So I wanted to make sure we had time for this. We're actually going to use the 2 assessments that we did. We're going to turn them into exercises. So that kneeling, that hands and knees rock back, that is a really great place to start for exercise. And so we're going to talk about this in the sense of mechanics, which is kind of what we talked about in the beginning, which was the head of the femur has to stay centered in the socket. So when I do my rock back, the motion, again, it's neutral spine here. I don't know if you guys can see let me tuck this in. Neutral spine here. And then I want all the flexion to come from my hip joint. Okay, so I'm not rounding under, but I'm staying neutral, bringing my butt towards my heels. What you're going to imagine and visualize as you do this is, here's the head of the femur, right? So it sits right in the center here. As I go into flexion, if you remember, the head of the femur has to drive down and back into the socket. So again, this is where I need length in those posterior pelvic floor and glute muscles, because it's got to have somewhere to go. And so if it's too tense and too tight back there, it can't actually drive back into the socket. But if you just visualize head of the femur going back towards your heels, what it's going to do is it's going to release those hips so that you actually get the crease and the flexion there. That's what we need. We need that easy flexion motion. Too often, what people will do is they will tuck under, they will tense their glutes, and then they sit back. And so, what happens is the head of the femur actually drives forward in the socket, and then you sit down on it. And so, you get that anterior compression. And that's what we're trying to eliminate. We're trying to get the head of the femur to glide in the center of the socket, which means lots of relaxation through those hips, lots of flexion happening through the hip versus through the spine and the butt tucking. And we're going to get that glide restored. And so, what you do here as the exercise, it's really just this, it's learning the movement pattern. And you're just back and forth out of that motion. Remember, you can be knees out, toes together if you need to. And you're just relearning that movement pattern. So, this is a muscle memory thing, a muscle retraining piece. But keep in mind, this often, for many people, it actually reduces their pain. So if you start to feel pain in your hip, what you can do is you can try this exercise and see if it makes your pain actually start to feel better. Because if it does, now you've got a daily exercise to help you feel really good. So breathing, quadruped rock backs, and then the third one is relearning how to squat. Now, sometimes this is jumping a little bit ahead for some people. However, what I find is pretty much everybody that walks in my door or onto my Zoom, my goal is to try to get them squatting within the first 1 to 2 sessions. And the reason for that is you are squatting all the time, every day, anyways. Every time you get up and down from a chair, every time you get up and down from the toilet, in and out of the car, picking something up off the ground, we have to squat. It is a functional pattern of life. And it's also one of the big things that reproduces symptoms. So my goal is, can we get you squatting as early in this process as possible so that life doesn't hurt as much anymore? So here's the trick to being able to squat with good patterns and not feeling the pinch. So if you remember, what I said is what usually will happen is people go, adjust a little here. Most people walk into my office and they're like, okay, I can squat to here. They're like, I get stuck, it hurts, it pinches, I just can't go any further. And if I do, it makes it worse. And so if you look at my positioning here, what's happening? I'm really far leaned forward. I have no space in that joint and I can't get my butt down because it's just, there's nowhere to go. But I have to be here because if I'm not, I feel like I'm going to fall over, right? So we naturally, our butt is out, our trunk is forward, I've got no space, but at least I don't feel like I'm going to fall over. The problem with that is it leaves no space in the joint. So that's why you feel that really intense pinch, because it's a lot of hip flexion. So here's what you're going to do instead. You're going to find a step stool or something. This is about 12 inches. I usually do 12 to 14 inches with people. And what you're going to do is you're just going to try to sit and stand. Okay, just sit down, stand back up. Now, you could also use this as an assessment in itself to see when you do that, does it still hurt? Because for a lot of people, that doesn't hurt. But when they squat, it does. And so that's kind of a test in itself. The reason that this often will feel better, though, is it completely changes my weight shift. So when I squat or sit to stand from the box, notice what happens with my knees and my trunk, right? I don't have to lean. I'm not down here. I don't have to lean so far forward. I can be up a little more upright. And it's because my knees shift forward over my toes. So if I allow my knees to shift forward over my toes, my trunk can be more upright and I don't feel like I'm going to fall over. As opposed to if my weight is all the way back in my heels, my knee don't go in front of my toes. The only way to not fall over is to lean forward. No space. Now you've probably heard before, don't let your knees go in front of your toes. And I am here to tell you that is not true. Do not do that because your hip will continue to pinch if you do. It's also not very functional because when you get up and down from a chair, that's not what happens. Your knees have to go forward over your toes. So when we squat, we just want to replicate that. And again, it should take care of the pinching and we can retrain that movement pattern and make sure that it's more functional for you in day-to-day life. So when I do it here, it just naturally teaches you the weight shift without you having to think about anything. Because in order to get up and down from this, the only way to get there is for my knees to shift forward and out. As opposed to like if I tried to keep my weight back, I might be able to get down, but I can't get up. My weight is all in my heels. I I can't get up, or I really am going to struggle to get up. But if I just stand up, I get that shift. Guys, that's a squat right there. So what we usually start with is a sit to stand, turns into a tap and go, or a little box squat, and then eventually an air squat. Same pattern, just stepping away from the box. This is how I teach people to squat again. Well, if we kind of go through the sequence, we calm the hip joint down by breathing, re-regulating the nervous system. We learn how to keep the head of the femur centered in the socket with a little bit of that rock back motion and just retraining that pattern. And then we take it into a functional pattern, which is the squatting, which essentially is helping you keep the head of the femur centered in the socket, but doing it in a way that doesn't create all that compression and that repetitive stress on the front side of the joint. Guys, this is how you manage impingement and labral tears conservatively. You relearn the patterns that you have to do in daily life already, but you learn them in a way that takes the stress off of the joint. Now, is this possible for every single person that has impingement and labral tears or dysplasia? Not always, right? Sometimes the structure is impacted enough that we do still have to have surgery, because even with these little changes and modifications that we make, it still pinches or it still has a problem. From my experience, though, the majority of people, as soon as we teach them this, the problem goes away. Or, I mean, it takes time, but like eventually the problem goes away and they don't ever actually have to have surgery. But even if surgery is the outcome, and I see plenty of people where surgery is the outcome, if they've learned the movement patterns now, recovering from surgery is 10 times easier because they've already built the patterns that their hip needs post surgery. They've already learned how do they move that takes the stress off the joint, because just going in and changing structure is great, but it is nothing if you haven't learned how to move. So you've got to do this part anyways. You might as well do it before, because it helps it helps recovery on the backside. And for many people, it just means that they don't actually ever need surgery. It's just that nobody has ever shown them this. Is this different for you guys? Has anybody ever like shown you how to do these movements? So, all the time, like one of the number one comments I get is like, I'll say on my social media or whatever, like, learn how to move. And people are like, what does that even mean? Like, what are good movement patterns? I don't understand. I hope that this makes a little bit of sense. Now, this is not all of them. This is just 3. But these are the types of movement patterns that this is what I mean when I say learn to move with good patterns. We can take these and we can pull it into the more functional patterns of life. And, right now we kind of just started with the baseline level of things, but eventually these things, they build on each other and you go to the more complex movements, the more impact, the harder things. Just as an example of like, because we did the squats. So like an example of progression would be, okay, great, we can squat on 2 legs. Now it doesn't hurt. So now I can load that and we can actually get you stronger. And now your squats don't hurt you anymore when you add weight on top. So I can get stronger. And then maybe we turn that into a single leg squat, right? Because single leg squatting, if you're somebody who maybe wants to be a running is a single leg squat with a little bit of jumping over and over and over again, right? Very repetitive. But if I can't do a squat, I can't do a single leg squat. And if I can't do a single leg squat, I can't add the jump. And if I can't do that, I can't run. So base movement, how do I flex my joint? How do I squat? Can be taken all the way up to how do I resume running? And this is what we do. We build the function of the movement pattern. We strengthen it. We challenge it. Rinse and repeat. Whatever muscle movement it is for your body, it's going to be a little different for everybody, but that's the process that we want to follow. So hopefully these 3 things at least give you an idea of where to start. Last thing that I want to say on this, if you guys are at a point where you're like, you know what, this is definitely something that I'm not getting. I want to learn how the heck to do this. How can I do it and apply it into a way that works for my body? Like basically what is next? This is the start, but like, where do I go with this? What is next? I do want to share with you guys I'm going to share my screen here really quickly so that you can see it. Pull this up here. So I do have a group coaching program. Now I'm putting this up here. It is not currently open, so it's nothing that you can jump into right now, but I figured let me at least mention it because if some of you guys are on here and you're like, this was extremely helpful and I am not getting any of this with the PT or program that I'm working with, the group coaching program might be a really good solution for you. So essentially what this is I walk you through this framework and we do it through a series of weekly group coaching calls. It's an 8-week program. So you get a weekly group call where you can ask your questions. You learn sort of a little bit of a topic every week that walks you through this core framework that I've talked about. And you then get a semi-customized exercise program that goes along with it. You also have access to weekly video modules. So you're learning even outside of the calls with me. You have access to a lot of information that is going to walk you through how to implement some of this. And then you have a customized exercise or a semi-customized exercise program for each phase of the process. There is a community of people in here. So I actually have made the decision to only run it with 5 people at a time. So it's a very limited number of people. But the reason we're doing that is it allows it to be as customizable as possible for you, the participant. So you still get the community of the other people in the group who are going through the same thing you're going through, which is really powerful to just have that support. But you also get it in a semi-customized way. This is as close to working one-on-one with me as you're going to get for a fraction of the price. And the other great part about this is if you have a flare up or you feel like you get stuck, you have access to me to not have to figure out it alone. So you don't have to be on ChatGPT going down a rabbit hole of like, what the heck do I do? Did I make it worse? You can just ask me and I can give you some suggestions. So again, this program is not currently open. It probably will not open again until July. So it's going to be a little while. There's a group running through it right now. But you can join the wait list. So all you got to do is scan that QR code, put yourself on the wait list. We can get the process going where I can actually have you do the application and give you access to some of the materials early if you wanted to get started early. But this will allow you to at least be first access. Anybody who's on the wait list also will get a discounted price. And of course, first access, there's only 5 spots. So it is quite limited. So if you think you might be interested, at least put yourself on that wait list. It doesn't, secure your spot or anything like that, but it at least gets you first access to be able to join when it does open up again. So that is an option for you in case you are interested. Let me close out of here. And then the other quick thing that I will mention is since that course does not open until July, which is a bit of a ways off, but you're like, I want some help right now, you can also join the HIP Lab. The HIP Lab is the self-paced portion of the course. So this in here, you will get access to all of the video modules and how you can start basically what we did today of like, here's some assessments, here's some exercises that would help you based off of those assessments. And it starts to kind of build a little bit of a program for you. It's not a plug and play exercise routine. It's not customized, but it will teach you how do I take all this information and turn it and apply it into the things that I'm doing so that I can actually start to get some relief. So this is an option if you were like, I really want some help right now. I don't want to wait until July when that group course opens up. Here is the link if you did want to join the HIP Lab. It's $349. If you do join currently during this call, you'll get a free 20-minute one-on-one session with me as well. So go ahead and scan that QR code. You do have just till the end of the call to do that. So if you think you want to join this, I would just do it right now because then you get a free call with me and we can talk through your situation. Again, with that, you get the 4-phase framework and you have lifetime access to the program. So you work through it, each of those four phases at your own pace. There are checkpoints. It tells you when you need to progress, maybe when you need to back off. And it walks you through that. So there isn't necessarily a time attached to it. It's just based on how well you do. So those are the 2 options if you feel like you're wanting a little bit more. You've got the HIP Lab where you can do self-paced right now. You could start that right today when we're done. And then if you are like, I want a little bit more guidance, the group program is probably a great option for you. And that will just start a bit later on. So you can scan the QR code to do the wait list for that. All right, I'm gonna read through, see if there was any other questions. Does anybody have any questions? If you do, drop them in the chat because I'm gonna read through and see what we have. I think I saw one. So Ariel, my physio hasn't mentioned any of this, but I have a strength training coach who has done all of this. Okay, that's awesome. Feels kind of frustrating. Yeah, it should feel frustrating. It's super frustrating. Um,
Yeah.
to be honest, most PTs are not very good at doing this, and it's terrible. But it's super frustrating. So having somebody who is specialized in it is quite important because this is what they'll walk you through.
Okay.
Yeah. But I'm glad that you have a strength training coach who at least is doing the
So
stuff with
kind of
you.
get
Like,
it.
yeah, that's huge. It's really important. So
Yeah.
sounds like you're on a good path with that. So hopefully that's been working. But if you're feeling like I'm plateaued or like I'm getting stuck, then of course maybe there's just something missing from the equation. Um,
Right.
maybe a different movement pattern or something
Yeah.
in a
I
different
have
imbalance that you haven't
impingement, a
found.
bad tear, and dysplasia,
Mm.
and they think I might have EDS too. So
Hmm.
it's kind of like everything all at once.
Yeah. Well, see, you're a good example of these things all kind of go hand in hand. So
Yeah.
many of my clients are the same. They have all of those things. And it doesn't mean that it's any, like, you can still do this really effectively. It's just other
Right.
things that have to be sort of taken into consideration. But to be honest, a traditional physical therapist maybe isn't very skilled at looking at. I think hypermobility is a big one where PTs don't do, unless they're used to working with it, they just don't do a good job of like really understanding it. So that can be quite
Right.
frustrating.
Yeah, it is.
Let's see. PT wants me to train my hip flexors. Is this a good idea? Yeah, so it depends. We did not do any hip flexor strength things here. I will be honest, I don't always start with hip flexor training because what I find is it tends to reproduce people's symptoms pretty quickly. As we mentioned, hip flexion is often one of the most aggravating factors. And so to strengthen hip flexors, you have to go into hip flexion. So if you haven't learned how to move your hip in a way, remember, it all comes back to can the head of the femur stay centered in the socket? If you haven't learned how to do that and you haven't made that a normal movement for your body yet, you don't know what that feels like. Every time you go to strengthen your hip flexors and you get that forward glide, it's going to reproduce your symptoms. So strength training hip flexors, definitely a good idea. Doing it with really good mechanics, even more important. So as long as you do it in that order and it's not reproducing pain and symptoms, then you're good to go. Just make sure you understand how to move the joint. And so again, even just that quadruped rock back can be a really good starting place, but then you have to learn how do I translate that into doing it against gravity? Because to strengthen the hip flexors, you have to do it against gravity. So can you still replicate the head of the femur staying centered in the socket when you're standing, marching, or squatting, or whatever else against gravity? So that's why the order really matters there. How many times a day to do the exercises? I would say at least once a day. What you're really trying to find is you're trying to find things that make your hip feel better. So if they make your hip feel better, you can do them multiple times a day. A lot of times in the beginning, what I'll tell people is try them, try the exercises. Do you have less pain after? If the answer is yes, then okay, we've found a good set of starting exercises for you to start to calm your symptoms. If that's the case, do them as often as you need them. Every time you feel pain, try 10 of them. Can it get your pain level down? Because if it does, then we're in a really good place of starting to figure out what do I need to do to calm my hip joint. Remember, phase one is calming. We do more of what feels good, less of what doesn't feel good. And so at least once a day, but honestly, if it makes it better, you can do them multiple times a day as needed. Certainly, if it's making your pain hurt more, that's a different situation. Do not push into pain. Do not push into pinch. Do not push into catching. You probably need to modify the movement a little bit. So don't ever push into that just because she said to do them once a day. Make sure they feel good to your hip and that makes your hip feel better, not worse. All right, I think that was the last question that I had in there. Let me know if anybody wants me to pop any of the QR codes back up on the screen. I'm happy to do so. I will also send you an email with the replay as well as links to all of that information in case you are interested in joining any of these programs. But thank you guys so much for joining me. I hope that this was helpful. I think that, again, these are just things that are really often overlooked. So if you are feeling frustrated, if you are feeling stuck, if you feel like you have tried everything, I just want you to know that there probably is still something else that you can do for it. There almost always is something else. There is most definitely hope to be able to solve this issue. So you probably just haven't found the right strategy yet. So I'm happy to help you along with that if you feel like you need it. Thank you guys, and I hope you all have a great rest of your day. We'll talk soon.